The following podcast is part of a certified educational activity titled Plugging the Gaps in Hepatitis B and C Care, Understanding and Integrating New Guidelines and Advances in Disease Management. Access the entire activity and complete the post-test at peerview.com/EWQ860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Nancy Rowe from Rush University. Welcome to this educational program on understanding and integrating updated guideline recommendations into the management of hepatitis B and C. Our goals for today are to augment your knowledge on the guidelines for Hep B and Hep C screening and treatment, equip you with strategies for implementing care plans for hepatitis B prevention, diagnosis, and management, and to provide guidance on strategies to address hepatitis C transmission and achieve sustained virologic response. We'll achieve these goals through a series of educational modules that will explore these topics. Let's begin by introducing my colleague, Dr. Sue Wong, who will start with discussing ongoing gaps in hepatitis B and hepatitis C virus screening and diagnosis. Thank you so much, Sue.
Great. Thanks so much, Nancy, for the introduction, and excited to kick us off. We're talking about how we mind the gap and what are those ongoing gaps in new guidelines in screening and diagnosis to help close those gaps. All right, let's meet Rob. Rob is a Black male, aged 24 years. He's here for a physical and a review of his asthma medication. He's saying this is his first time having a full checkup and getting blood work after many years. So how would you explain to Rob that he should be screened for Hep B and Hep C? And what tests would you order for Hep B and Hep C screening? So think about those, and let's explore how you might answer these questions. And we'll talk about that too in terms of what are the next steps. All right, so let's start off with some background on the epidemiology and burden of hepatitis B in the US. So it's estimated that 880,000 to 2.4 million people are chronically infected with hepatitis B. And 89% of those newly reported cases occur in persons over 30 years of age. And that's largely because of the pediatric Hep B vaccines were not available at that time. The rates of newly reported Hep B cases among non-Hispanic, Asian, and Pacific Islander persons was 11.2 times as high as among non-Hispanic white persons. So this is definitely a disproportionately burdened population with hepatitis B. And in terms of deaths, the deaths among Asian Pacific Island persons and non-Hispanic Black persons were 8.5 times and 2.6 times as high as the rate among non-Hispanic white persons, respectively. So in terms of Hep C, it's estimated there are 2.8 million people in the U.S. living with chronic hepatitis C, and the number of acute cases in 2022 was 3.5% lower than the cases reported during 2021. Non-Hispanic white persons accounted for 64% of all Hep C listed deaths. That's 2.7 deaths per 100,000. And the death rates here, we see some disparities as well. So it's 3.3 times higher in American Indian, Alaska Native persons, and 1.7 times higher in non-Hispanic Black persons. So in terms of how we're doing in terms of reaching elimination, so the WHO does have elimination goals by 2030. And let's see how we're doing in the US. So in terms of new infections, the WHO strategy is to reduce new infections by 90% before 2030. And then in the US, we have a 2025 target to reduce estimated new Hep B and Hep C infections as well. So for Hep B, this was a report that came out recently. For 2022, we did meet the targets. And our new infections was 23% lower than the goal of 18,000 estimated infections. For Hep C, unfortunately, we are not meeting the annual target. So in terms of how we're doing with the deaths for our goals, the WHO goals is to reduce by 65% of hepatitis-related deaths before 2030. And let's see how we're doing in the US in terms of our 2025 targets. So for hepatitis B, we did not meet these targets. And then for Hep C, our target was met, and we exceeded the target for Hep C, and it's 4% below the 2025 goal. And we think this could be attributed, obviously, to the success of antivirals in treating and curing many people with Hep C. So what are these updated screening recommendations? And this is really great news that the CDC has published updated recommendations for Hep B screening and testing. This just came out in 2023. We think this will be really instrumental to getting us to elimination. So it's now recommended that we screen all adults over 18 years of age, 18 and over, at least once in their lifetime. So these universal recommendations are simpler, less stigmatizing because we're no longer assessing risk factors. And we think they're going to be more comprehensive and get more people screened. So in addition to the universal screening for all adults, we also want to screen all pregnant people during each pregnancy for surface antigen, preferably in the first trimester, regardless of vaccine status and previous testing. And then for those people who are susceptible or not immune, we want to test them periodically if they have ongoing risk factors. And we'll talk about that later, what those might be. So CDC recommends triple panel test, which includes the Hep B surface antigen, the hepatitis B antibody, surface antibody, and a total anti-core test. So in terms of interpretation, we always tell people this it can confuse people, but this table is always available on the CDC website if you need help interpreting the serologic results. But basically, everything's negative. All three tests are negative. This means that somebody's susceptible. They could use vaccination to help protect them from getting hepatitis B infection. The next row you see is somebody who's got core antibody positive and surface antibody positive. And this shows that somebody was exposed to hepatitis B before, but they've resolved their infection. But the cccDNA of the virus lives in the liver, and they can always reactivate, similar to what happens with chickenpox and zoster. For the third row, you've got somebody who's just anti-HBs positive, and this means they're immune from previous hepatitis B vaccine. For the next row, we've got somebody who's surface antigen positive and has total anti-HBC, and this shows that they have current chronic hepatitis B infection. And you want to evaluate them with viral load and also make sure you screen for Delta. The last one is what we call the isolated core antibody test. So somebody just tests positive for core. And it could be a couple of things. One, it could be a resolved infection. This is just the most common, and they just have lost antibody production, but oftentimes they have an anamnestic response if exposed, and the memory cells will start creating antibody again. Number two, it could be a low-level occult hepatitis B infection. Number three, it could be resolving acute infection. We just haven't developed the antibodies yet for surface antibody. Or lastly, it could be false positive anti-HBC, and it could be susceptible. But this is more rare nowadays with our sensitive tests. All right, and then now we're going to talk about new hepatitis B recommendations. So in 2022, ACIP, also supported by CDC, have switched from a risk-based vaccination approach to a universal recommendation. And now we recommend vaccinating all adults aged 19 to 59 with Hep B vaccine. So this universal vaccine strategy, similar to what was done for screening, removes the need for risk factor screening and disclosure and aims to increase vaccine coverage. And it was shown to be cost effective. So now, what about for people who are over 60? So those who have risk factors should be vaccinated, or even if they don't have risk factors, but if they want protection or asking for vaccine, it's recommended that they can be vaccinated. So the table you see here are the 5 options we have now that are FDA approved for hepatitis B vaccination. The top 3 are vaccines that have been around for decades at this point, and are a series of three shots. The newer one, which I think is interesting and just want to make sure everybody is aware of, is heplisav-B, which was approved in 2017 and is a 2-shot vaccine series. So you give it, you can complete it in a month. And this is really a game changer because we've seen this really double the completion rates because a lot of people never came back for this 6-month follow-up for the previous vaccines. It also has higher efficacy. We're seeing that this is really important for those who are non-responders to previous vaccines. Non-responder meaning that a surface antibody level of less than 10 IUs. Or there are many people who do have risk factors for non-response. So you may consider this, if you're not already doing this as kind of your first-line vaccine, but you may opt to do this for people with risk factors such as obesity, smokers, people with diabetes, liver disease, or who are immunocompromised, who may be less likely to respond to the traditional vaccines. So we just want to make sure that people are aware of that. And there's a newer one, PreHevbrio, which is a vaccine to 3 antigens in 6 months, but has been shown to have higher efficacy as well. So next, we're going to start about Delta testing and who we would want to do a test for hepatitis Delta in those who are surface antigen positive. So the WHO guidelines, which just came out this year, does recommend universal anti-HBV antibody testing in all individuals who are surface antigen positive. So in settings, though, where you may not have Delta testing available, the priority should be given for those at risk. And this is our current Delta screening process that you would first test for our anti-HBV antibody. And if that's positive, then proceed with HBV RNA to confirm the infection. All right, we're going to move to Hep C now in terms of screening recommendations. And so CDC actually has had universal Hep C recommendations for a number of years. And there also are to test everybody once in adulthood, test people in pregnancy during each pregnancy. So except you may not do it where the prevalence in your area is less than 0.1%. And then similarly to Hep B, you would do routine periodic testing for people with ongoing risk factors, regardless of the setting prevalence. All right, so what are the test recommendations for Hep C? So we would recommend a Hep C antibody with a built-in reflex so that a patient does not need to come back for a follow-up test if their antibody test is positive. So we've got a table here kind of showing what the results are too. So if their Hep C antibody is positive, but the PCR is negative, that can mean they have a past infection, but not a current infection. So it's really important to be able to get that PCR test after that HCV antibody to confirm current infection. All right, so I want to turn to my panelists now after this to kind of talk briefly about how they're seeing best practices in terms of implementing universal screening for hepatitis B and hepatitis C. Nancy and Stacy, you guys have some thoughts?
Sure. I think really routinizing in a routine opt-out way, all of the screening is really the path to success. And I think there are ways that our electronic medical records can really be leveraged to support some of this, whether it is incorporating routine screening within order sets for new patients or annual well visits, if it's somebody who's at ongoing risk for infection. But I think leveraging our technology is the key to just making this seamless part of primary care.
Yeah, I really agree with Stacy. In our own institution, we're fortunate enough to get a grant that looked at things that increased screening, such as universal ER opt-out, broadening that to primary care practices, and then, really pretty much anyone that hit the institution. And then having a navigator, or at least having those positive results hit the hepatology inbox so that we were sure that someone tried to re-engage that individual. We found that primary care patients were actually pretty easy to re-engage because their family doctor was also part of that conversation. And we struggle, as you would imagine, with trying to link individuals that came to the emergency room or, through less long-term relationships. But then, we try our best, and we figure if we get about a third of them linked, that's better than nothing, because we really do want to work towards curing these people to prevent transmission as well as morbidity and mortality.
Yeah, that's great. I want to echo what Stacy was saying in terms of really utilizing your EMR as much as possible. And, I think many of us, work closely with the Epic team, Epic, if you have Epic like we do. And, you want to push for certain things. Like we realized that they weren't, we didn't have the latest recommendation for CDC and our care gaps. And so kind of making sure they're following the now recommended by CDC guidelines is really important, so that they show up, in the area that reminds doctors that a patient needs to be screened. And then also if you can create a registry so you can find patients who were tested and maybe didn't follow up, there are other ways of kind of managing patients who've been tested but haven't been linked to care, as you guys mentioned. So great. All right, well, let's move on to our next topic. Let's come back to Rob and discuss which tests were ordered and what his results show. So his Hep C test was negative for the antibody, and so then the PCR doesn't get done. So this means that He's not been exposed and he does not have infection to Hep C. There's nothing to do. But if he does have any exposures after this testing, then it would be wise to test him again. For hepatitis B, he was also negative for all 3 tests, which means that he's not immune, but also not infected, and that we would recommend that he get vaccinated. All right, so our summary is that we've got quite a burden of people living with Hep B and Hep C still, and we are not quite yet meeting all of our targets in the U.S. for elimination. A lot of people are still unaware. The estimates are up to 50% or more actually have not been diagnosed yet in the U.S. And so we want to approach this with a strategy of universal screening, making sure all of our patients that we come across had at least a one-time test for hepatitis B and C. And we're gonna move on now to Dr. Rowe talking about perinatal infections.
Thank you so much. So really, perinatal transmission is key for hepatitis B. Dr. Wong really emphasized our huge burden, and the best thing about hepatitis B is a vaccine-preventable disease. And so in theory, even if we can't cure the disease, we really can eliminate new infections, although we're woefully behind what the WHO would like us to be. So let's meet Aliyah. She is a Pakistani female. She recently moved to the United States. She's 28. She's married. She's currently early in a pregnancy with a second child. She's known to be hepatitis B surface antigen positive, or she says that she has known hepatitis B. She doesn't have much other information about that, as that wasn't really available to her when in Pakistan where she was living. And the question is, what would you recommend for testing for her? We're going to come back to this after we go through a little more background information. So why do we focus on perinatal infections? Because for a long time, screening for hepatitis B in pregnancy has really been emphasized. Well, that's because, number one, early exposure is linked to chronic disease, whereas exposure in adulthood is often linked to symptomatic disease, but not chronic infection. And so 90% of newborns who acquire hepatitis B through either maternal to childhood transmission or very early exposure through households or community spread will have a high risk of developing chronic hepatitis B. And then that's going to decrease over time. Elimination targets for maternal to childhood transmission of Hep B are real, and they are very conservative. You want less than 0.1% prevalence of hepatitis B surface antigen in children that are 5 years or younger, really driving home that this is the population that really propagates chronic hepatitis B. And how do we do that? Well, most of that is done through birth dose hepatitis B vaccine or active passive immunization, and then trying to engage those higher risk mothers that are at risk to transmit disease despite active passive immunization with active antiviral therapy. And you can see in the US, we are not doing a great job. You imagine in a resource-rich place where we have lots of electronic medical records and way of tracking things and multiple excellent guidelines, we really only managed to do a timely birth dose of hepatitis B vaccine in a little over 80%. And this has been unfortunately consistent. So you would think we would get better, but we kind of are stuck right here. We do a little bit better with a 3-dose vaccine series by the age of 24 months at 92%. And testing for hepatitis B in pregnant women is not terrible at 82%, but it is still should be close to 100%. There's no reason we are not following testing guidelines for routine pregnancy. Where we really fall apart is looking at those that have continued risk despite active passive immunization and then giving them antiviral therapy to decrease that risk. Here we're around 13% in the study that's listed on this slide. The WHO does recommend prophylaxis of pregnant women. So it's not just the US trying to be, ultra resource rich. The WHO wants us to use hepatitis B DNA as a metric to allow us to identify women that are likely to transmit to their child despite active passive immunization. And their recommendations have changed a little bit over time. So as early as 2020, their updated recommendation was in a woman who had hepatitis B DNA greater than 200,000 international units or had hepatitis E antigen that was present, that they should be offered tenofovir in the form of TDF to prevent maternal to childhood transmission. and that should continue until the end of the pregnancy. So start in the second trimester, continue until the end of the pregnancy, or until the Hep B vaccine series in the infant has been completed, really to give them the ability to protect themselves from exposure. In 2024, the WHO changed their recommendations or improved upon their recommendations. And now, in addition to that, they also recommend prophylaxis with tenofovir in the form of TDF to all hepatitis B surface antigen individuals, even if you can't measure hepatitis B DNA or E antigen. And again, through the pregnancy until delivery or until vaccine series is completed. The impact of these new prophylaxis strategies are really paramount. If you look at universal TDF prophylaxis, it could, in theory, avert an extra nearly 5 million neonatal infections by 2030. So when we're trying to look at hepatitis B elimination by the WHO recommendations, this is really important for that. We also know that if you use tenofovir prophylaxis in Hep B surface antigen positive persons who are Hep B DNA viremic at greater than 200,000 international units, you would estimate avert an estimated additional 1.1 million individuals with neonatal infection by 2030. So even if you're doing a more conservative approach, you're still decreasing a lot of chronic hepatitis B. And TDF can be continued in more pregnancies that are planned or anticipated, so you don't have to stop it if that mother is very likely to get pregnant again soon, or even more importantly, has indications for hepatitis B therapy independent of pregnancy. We do have ongoing gaps, though. So there are discrepancies in the rates of birth vaccination dose, even in resource-rich settings such as the U.S., and infants born in the U.S. between 2017 and 2018, only 77% received a birth dose of hepatitis B vaccine. Now, we do catch up when individuals or children meet their pediatrician, but that's, not going in the right direction. Also, in 2022, only 45% of all newborns were given Hep B vaccine dose at birth. And maybe, we can discuss that as a group, but maybe that's a reflection of some of the vaccine hesitancy that occurred with the COVID pandemic. I mean, I think that, there are lots of my patients now that are afraid of all kinds of vaccines when they used to be a little more run-of-the-mill. And then neonate and infants might be exposed by other household members. So it's important to really emphasize these birth dose vaccines, because if you're born into a family where someone else has hepatitis B, even if your mother was negative, you might still have the opportunity to be exposed to someone and get chronic hepatitis B. So I'll open this up to my colleagues. Sue, Stacy, why do you think that our neonatal vaccine rates are going down?
Yeah, that's interesting. I had a conversation recently at our institution too about this, and I think what's a lot of it comes down to a couple practical things. So, actually, a couple years ago, the AAP, the American Academy of Pediatrics, also endorsed this recommendation that babies get their birth dose within 24 hours. It used to be there was a little bit more leeway into a week after, and so babies were often getting it in the office at the post discharge visit, but it moved to 24 hours. And so hospitals that actually updated their policies, that made a big difference, but not all hospitals did that. And so if the baby's being seen by outside hospitals in the nursery for their well baby check, sometimes they will say, oh, it's okay for you to get it at the pediatricians. And so that's a little bit of that gap. But I agree, there's some element of, I think, vaccine hesitancy too. So I think we really got to increase the awareness on this, because not everybody realizes that just because the mother doesn't have Hep B, that there's no risk. Because like you mentioned, family members, also nannies, other people who are around the baby could potentially expose the baby. And that risk of chronic infection, I think, is just something we want to avoid if we can, at this early stage.
I think there's also a real opportunity here to make sure that postpartum staff are comfortable talking about the vaccine as well. So if a family expresses some hesitancy, being able to have a conversation that addresses some of the hesitancy or maybe some of the concern or misinformation around the vaccine, particularly if the first dose is being given in a hospital setting, which is ideal from a timing perspective. Hospitals, as we know, are limited on time and may not have the opportunity to really sit down with the family and understand, like, why are you worried about this? Why are you declining? But I think it's really important to address some of the misinformation and to provide reassurance to families. And so making sure that staff have training around that, making sure that culturally sensitive conversations are happening as well when certain populations or community members may have a higher level of mistrust of the medical establishment. But all of that, I think, is valuable and could go far in addressing some of the gaps that we're seeing.
We really didn't talk about it earlier, but part of the recommendation is also in these mothers that are triple screened. If they are Hep B surface antibody negative and core antibody surface antigen negative, they should be vaccinated in their pregnancy. And I think that messaging also helps with that neonatal vaccine, because if it was safe enough for my pregnant mom to get it, then it's definitely going to be safe enough for baby. I'd like to come back, though, to that ridiculously low amount of tenofovir being used to prevent maternal childhood transmission in these higher viremic mothers. Are the two of you also seeing that mothers are hesitant or providers are hesitant to give this to help drive down the virus and capture that small risk of escape?
I think a lot of it is actually about that linkage to care, right? So a lot of times the obstetrician may not be the one who feels comfortable treating somebody with Hep B. And so they need to refer, and, you have a short window of time, right, during pregnancy. And so sometimes, at least in population I used to work with in New York City, where we had so much hepatitis B, by the time the mother was able to get to a hepatologist, they may not get to the hepatologist, right? So they may not get that recommendation or they may not get another viral load, or get the prescription for tenofovir. And so you missed that window of time. I think some of it is our surveillance too, and that we're not doing a great job catching all that. But yes, in that one case, it was alarmingly low, I think, right, for women, over 200,000 to see only 13% treated. So it's definitely an area that we need to work on.
Well, thank you both. I think we'll go back to our case now. Let's go back to Aaliyah. Her lab results today show that her Hep B DNA is 250,000 international units per ml. Her ALT and her serum creatinine are normal. Her first child, thankfully, is hepatitis B surface antigen negative, and hopefully you were vaccinating or ensuring that child was vaccinated. After discussion, you and she decide to initiate tenofovir in the form of TDF, since she is Hep B surface antigen positive and her viral load is above 200,000 international units, increasing the risk of maternal childhood transmission to that child, even with active passive immunization. And you want to start this in her second trimester. The next steps that we need to discuss are really the initiation of hepatitis B vaccination at birth, and the importance of completing the vaccine series, as well as giving her passive immunoglobulin, or HBV. We're going to monitor her following TDF cessation. So some people would stop at the time of delivery. Some people would stop after a period of post-pregnancy exposure, like allowing the baby to have a vaccine series that's completed to minimize exposure from her family. Either way, irrespective of when you stop your tenofovir, it's important to monitor for flares because they do occur in about a third of the individuals, somewhere in the first 1 to 4 months after you've discontinued treatment. Now that we've spent some time discussing hepatitis B, let's hear from a patient about their experience living with hepatitis B.
So one important part I want to mention is in terms of disclosure of status. This is complicated and nuanced. And I think there are things that healthcare providers can do to bring sensitivity, support, and care. And so one scenario I have is, right, if a first-time mother is diagnosed with Hep B, well, while they're being pregnant, that being pregnant is already a lot of things to do with your body, hormone changes, right? Then to all of a sudden get this diagnosis, they start worrying about themselves. Oh, it's transmissible. I might pass it on to the baby or other loved ones. Ask the patient to, at the next visit, maybe invite their partner, invite the family member, and then come together at the visit. Let the doctor explain what the diagnosis is, dispel some of the myths and misconceptions, and then answer any kind of questions.
So in summary, there is significant need to prevent perinatal infections. Globally, hepatitis B transmission occurs largely from maternal to childhood transmission or early exposure in infancy and early childhood. Up to 90% of newborns who acquire hepatitis B through maternal to childhood transmission will develop chronic hepatitis B, so that this is really a key place to intervene. Hepatitis B vaccine is greater than 90% effective when the series is complete, especially in these young children. And pregnant people who are Hep B surface antigen positive with a viral load greater than 200,000 international units should also have second prophylaxis with tenofovir in the form of TDF. And the new WHO recommendations from 2024 really give you some additional wiggle room that if you can't do these additional tests and your patient or the individual is Hep B surface antigen positive, you want to consider tenofovir in the second trimester to complete through that pregnancy or until the child is completely vaccinated. All right, we're next going to move on to Dr. Treitskin, who's going to talk about hepatitis B treatment candidacy.
Excellent. So we're going to move on and discuss how we simplify, support, and expand hepatitis B virus treatments. So let's start off with another case and meet Michael. Michael is a young adult refugee from West Africa, about 21 years old. And the pertinent labs to review are his hepatitis B viral DNA level is 204,000. And his ALT is, in fact, greater than the upper limit of normal on 2 occasions over the course of 11 months. So we're going to discuss how would you determine treatment eligibility, and if Michael is a treatment candidate, how would you approach hepatitis B virus treatment selection and initiation? So together we'll explore how one might answer these questions, and we'll come back to Michael's case at the end of this section. So historically, there have been significant gaps in linkage to hepatitis B virus care. Patients with chronic hepatitis B in the U.S. have received inadequate monitoring and treatment, and there's a continued lack of awareness of and adherence to American Association for the Study of Liver Disease hepatitis B virus treatment guidelines. So recently, I'm pleased to share that the World Health Organization has expanded hepatitis B virus treatment eligibility. So Hep B treatment candidacy is typically determined by a combined assessment of the stage of liver disease and the levels of serum ALT and viral DNA. A U.S. population-based study showed that of those who were hepatitis B surface antigen positive with liver disease, only 4.6% received treatment. That is very low. Because prior recommendations were too restrictive or just not being followed, the World Health Organization provided updated recommendations in 2024 to include 4 options for treatment eligibility that applied to adolescents aged greater than or equal to 12 years and in all adults with chronic Hep B infection. Only one of the 4 treatment eligibility options requires access to hepatitis B DNA testing, which is really important for resource-limited settings, and that's long been considered one of the major barriers to accessing treatment. The 4 treatment eligibility options will hopefully deem a much higher proportion, at least 50% of all surface antigen positive people as treatment eligible, compared to just the 8% to 15% who are treatment eligible based on the previous recommendation. So let's take a moment and review the new World Health Organization guidelines for treatment of chronic hepatitis B. These were published in March of 2024. So we want to be treating all adults and adolescents greater than or equal to 12 years of age, including pregnant and non-pregnant people, and also individuals assigned females of birth at reproductive age that have one of the following. So significant fibrosis, which is greater than or equal to a Medicare score of F2, or cirrhosis, which is an F4, regardless of hepatitis B DNA level or ALT levels. They meet clinical criteria for cirrhosis, and you can be using non-invasive tests like an APRI score with a cutoff of greater than 0.5, or transient elastography, which is also known as a fiber scan, with a cutoff of greater than 7. The second eligibility criteria is a hepatitis B viral DNA of greater than 2,000 and an ALT level that's greater than the upper limit of normal. You can have also the presence of any of the following, regardless of APRI score, DNA level, or ALT level. So a co-infection, a viral co-infection with either HIV, Hep D, or hepatitis C, somebody who has a family history of liver cancer or cirrhosis, anyone who has immune suppression, or comorbidities like a diabetes, a metabolic dysfunction that has associated steatotic liver disease, or extrahepatic manifestations as well. And then lastly, in the absence of access to a hepatitis B viral DNA, anyone with persistently abnormal ALT levels alone. Right? So this really broadens the eligibility criteria from what we've seen in the past, right? If somebody has one of those 4 criteria, then we initiate antiviral therapy and monitor with any one of the options that are listed on this slide. So options include tenofovir in the form of TDF, or entecavir, tenofovir and 3-TC, which is also called lamivudine, or TDF and FTC, or entecavir or tenofovir in the form of TAF in persons with osteoporosis or impaired kidney function, or in children and adolescents. So we now have options. Only one of the 4 treatment criteria actually does still require hepatitis B viral DNA. So let's discuss guideline implementation. So I'd like to pull my colleagues back into this discussion and think about what those best practices are in the implementation of these new treatment guidelines for hepatitis B. So what do you all think about this? How do we get there?
I think this is a game changer. I think it's a game changer, especially for places where there are resource limitations, but it also pushes resource-rich locations to understand the impact of having other risk factors like family history, metabolic liver disease, and that you don't want someone to progress that already shows signs that they have the risk of getting liver damage. So it doesn't say that they have to have liver damage or fibrosis from their hepatitis B. It's just that if you have significant fibrosis and you have Hep B, let's at least control one of the factors that is actively easier to control, as opposed to maybe, diabetes. I think in the U.S., we are still going to use viral load as one of our thresholds. I think that we have that ability, and we definitely still use the measurement of viral load to be sure that our treatment is working. So not only to show that you need treatment, but also that your treatment is effective. But I really think that the simplification in these algorithms is very important, because Hep B has traditionally been kind of scary because the algorithm is very complicated.
I think what is really notable difference of this guideline from some of the other ones is we're moving away from really trying to first place patients in like those stages, right? So I think a lot of people through med school and even afterwards get scared by that natural history graph of hepatitis B with the E antigen and what phase they are. And I think it became clear through all our studies that patients are just not getting treated, right? Even those who are eligible were not getting treated. That Spradling study you showed from CDC just showed that even people who were getting tests weren't getting viral load tests. Even cirrhotics were not getting treated, right? And so that requiring the E antigen test and repeated studies, viral load was becoming a barrier, right? So this is really phenomenal in terms of saying, hey, we're not even looking at the E antigen status. Let's look at other other factors. And and not to say that those are important. I think they're still important for understanding where a patient is, but I think let's now simplify it so that even people who are not hepatologists or specialists can still care for patients with hepatitis B. So I think these guidelines allow us to now be able to care for Hep B patients in a primary care setting or frontline setting, make it easier, right? So I just think I'm an internist too and a primary care doctor. I see diabetes and I'm not an endocrinologist, right? And I may not do exactly what an endocrinologist do, but I still am able to provide diabetes care, which is so important because otherwise a large majority of people with diabetes, if they needed to see a specialist, would not get care at all, right? So very similarly with hepatitis B, if we only relied on specialists, a lot of people would never have access to care. And these oral antivirals are now safe and they're generic. So we're in a different scenario now than we were like 10 or 15 years ago. And they also have very low to non-existent resistance. So given that, I think this will be nice for us to be able to offer this to more patients, as a chronic medication like we do for other chronic, that way they can manage hepatitis B like any other chronic disease.
For sure. As somebody who works in a community health setting, in a federally qualified health clinic, I think really allowing us to bring treatment into a primary care setting, even as an infectious disease physician, it's much more accessible to our patients to not have to refer individuals. And for those who are uninsured or not documented, it really allows folks to access care in a new way and for us to overcome sort of the complex guidance that we were getting that I think led to a lot of paralysis in terms of treatment. And so hopefully this will really change things for us.
Yeah. Every time a patient has to move in the care cascade, you lose patients. And that handoff to a subspecialist is really challenging. Plus, subspecialists may not communicate well with the person that, they have to co-manage with, or the individual might change primary care providers. And so there's just so much disruption if you don't allow, the vast majority of easy to treat disease be managed in a setting where it's convenient for the patient.
100% agree. All right. Well, let's move on and talk a little bit about the impact that these higher treatment thresholds actually had on public health and the health of individuals who are living with long-term hepatitis B. So for patients with chronic hepatitis B, timely and effective viral therapy can inhibit hepatitis B viral replication. It can reduce liver inflammation and necrosis. It can stop or even reverse liver fibrosis and early cirrhosis, and reduce cirrhosis-related complications like hepatocellular carcinoma and liver disease-related mortality. And for this, the infectious disease physician in me thinks about this as treatment as prevention, right? Prevention of long-term sequelae, but also if we can reduce the viral load, hopefully we can also have the evidence in the future to support that maybe it'll also reduce transmission as we see in other viruses. However, when we delay treatment, there are negative health outcomes. So what happens if we lower the ALT thresholds for hepatitis B treatment? So serum ALT is commonly used as a surrogate marker of liver injury, and it plays a role in defining hepatitis B disease phases. Increases in serum ALT are not always parallel to the degree of liver inflammation. However, the risk for hepatocellular carcinoma increases with age and increasing viral load levels regardless of ALT. So lower ALT treatment thresholds are closely related to reducing hepatitis B related complications and deaths. So early implementation of expanded antiviral treatment strategies that were based on adjusting ALT thresholds will help reduce hepatitis B virus related complications and deaths. So we have come a long way. This slide will demonstrate to you that over the past several years, from 2015 as recent to 2018, we had much more complicated guidelines that varied depending on which professional society you were following. So this is part of this complexity is really part of what I like to think of as the paralysis that has led to so many people being undertreated is which guidelines do you follow? Which one does it say? Which criteria are you using for treatment? And it can be overwhelming, particularly to a primary care provider, but even to seasoned hepatologists. I know that when I've tried to go over this with infectious disease fellows and trainees, they often will have like a glazed look on their face and ask a lot of questions. So now we've evolved into a more simplified treatment approach. We acknowledge that there continue to be significant testing and treatment gaps. There is this emerging evidence that there's early integration of hepatitis B DNA, which can cause oncogenesis. And that is certainly concerning. We know that antivirals are safe. They're available in generic form, particularly in overseas, in resource limited settings. The previous guidelines are super complex. So we really have to simplify them to reach more people. And of course, we've already discussed the fact that there are access issues to diagnostics, particularly viral load testing, as well as specialists in many parts of the world, but even in the United States. And so we're now moving towards the simplified approach that is a little bit more streamlined. So how do we treat hepatitis B? We've already touched on this a little bit when I reviewed the 4 entry points for the World Health Organization. The drugs that we most commonly use are entecavir, tenofovir alafenamide, and tenofovir disoproxil fumarate as well. And then these dual regimens of either TDF and either 3TC or FTC can be used as alternative regimens in settings where access to tenofovir monotherapy is lacking, but where there is ready access to HIV therapies. So there are hepatitis B antiviral therapy recommendations for specific scenarios. So if access to treatment or cost is a consideration, ETV and TDF are available in generic forms. TDF in either 3TC or FTC also can be readily available in some countries, as we mentioned before. If antiviral resistance is present, we often want to avoid ETV if the patient has a history of 3TC resistance. If bone disease or renal dysfunction is a consideration, or either present currently or a risk in the future, then we may want to change to ETV or TAF, although we want to avoid TAF if creatinine clearance is less than 15 or if the patient is on dialysis. And then certainly we've talked about the pregnant patient as well, that TDF is certainly preferred in that setting. So let's finish up and follow up with Michael. So we repeated labs today, and hepatitis B viral load is still greater than 200,000, with the ALT greater than the upper limit of normal. If using the World Health Organization expanded eligibility criteria, Michael certainly meets the criterion for treatment. And then using that shared decision-making, you and Michael agree to initiate antiviral therapy, and we've discussed the options that are available. So in summary, studies suggest that patients with hepatitis B in the U.S. receive inadequate monitoring and treatment. There is continued lack of awareness of and adherence to AASLD treatment guidelines. Healthcare provider related barriers include lack of knowledge about hepatitis B and the benefits of antiviral treatment and surveillance. And the World Health Organization 2024 updated recommendations give you those 4 options, those 4 entry points for meeting treatment eligibility that apply to all adolescents greater than or equal to 12 years and all adults with chronic Hep B. And our expanded eligibility options will hopefully increase the proportion of individuals who have surface antigen that receive treatment. With that, I want to turn it back over to Nancy.
Thank you so much. So we're going to turn to hepatitis C. And although I think many of us imagine that Hep C is now eliminated, unfortunately, it still is a big burden, as was outlined earlier in these modules. We're going to meet Carl. He's a 29-year-old white man. He has a history and active use of injection drugs. He was recently screened for hepatitis C and found to be hepatitis C positive, which is not uncommon. He has no evidence of cirrhosis. He is 29. And we're going to talk next about some of the steps for initiating direct-acting antiviral therapy, how to monitor him, and how to support adherence. But first, we're going to come to talk a little bit about hepatitis C. So Hep C is bimodal in the United States, which means that there's an older population, which we previously called the birth cohort, and then a newer generation, which is more closely tied to injection drug use. And the strategy is to identify and engage these individuals in curative care are going to be really different. What you want to talk to your grandmother about is going to be very different than what you might talk to your child about. So newly acquired hepatitis C infections are in a younger population, often more demographics that are white, frequently associated with injection drug use, and those that live in non-urban areas such as Appalachian states are especially burdened. But really, this is a global disease. So there are places where there's higher risk, but does not mean that if you don't live in Appalachia, you don't need to listen to this. This is really something that is a problem everywhere. The AASLD does recommend direct-acting antiviral therapy very, very broadly. So unlike our Hep B guidelines, which used to be complicated here, it's really active infection, please engage in treatment, with very little conversation in between. They recommend direct-acting antiviral therapy that is pan-genotypic because it is effective and easily accessible, and you have minimal monitoring that you need to do while on treatment because the therapies are very effective, very safe, and as long as there's reasonable adherence, the expectation is that the person will be cured after completing their course of treatment. We have two therapies that are now considered pan-genotypic treatments. One is glecaprevir-pibrentasvir, which is 3 pills once a day for 8 weeks, or sofosbuvir-velpatasvir, which comes in both a branded and a generic form, and that's 1 pill once a day for 12 weeks. And although there are some caveats as to why you might pick one over the other, for the most part, the vast majority of the patient population that's infected with Hep C is going to be a great candidate for either treatment. So whichever one you have access to and feel comfortable using is almost always going to be a good fit for the person in front of you. All right. Despite the fact that we have curative, safe, accessible treatment, our DAA treatment rates are dismally suboptimal. And you can see that even in patients who are very high risk for disease complications, such as our patients with cirrhosis, a minority of them are still not getting treatment. And if we look at our patients who have injection drug use, nearly half of them are not getting treated. So overall treatment rates are at 65.2%. So the benefits of sustained virologic response, which is the definition of cure, that means that 12 weeks after you've completed treatment, your hepatitis C is tested in your blood and is not detectable. It is not an antibody test. You have to actually do a PCR, and then you are considered cured. If you achieve this milestone, there's a significant decrease in liver-related progression, so that if you can certainly have other liver diseases, but your liver from hepatitis C should not progress, you have a 70% or more reduction in the risk of developing liver cancer. This is monumental. You have a 90% reduction in the risk of liver-related mortality and the need for liver transplantation. That's why outside of liver cancer, very few patients are now transplanted for hepatitis C, which is a good thing. It's really a complement to incredibly effective treatment that should be more accessible than it is. We also see that there is an improvement in quality of life, a reduction in all-cause mortality. When we consider extrahepatic manifestations of Hep C, we really see that there's a plethora of autoimmune, of non-autoimmune injuries that are more frequently seen with hepatitis C, even if we don't draw a direct line. And these are things that include renal disease, type 2 diabetes, cardiovascular risk, non-liver related cancers. And so it suggests that something about this pro-inflammatory virus, or immune modulatory virus, really, if you cure it, improves the overall global health of the person sitting in front of you. So AASLD does recommend that you take care of your patient after cure, so that if your patient has no risk of ongoing liver disease, did not have advanced liver disease prior to that, and does not have risk for reinfection, they can go back and consider themselves a normal, healthy person. But the exceptions to that are if they're going to have an increased risk of exposure, you need to make sure that they're tested, not with antibody, but with PCR. And if they have ongoing risk of liver disease, you want to make sure that you are understanding how you're going to monitor that and at what point you would intervene and how you would intervene. So let's turn a little bit to microelimination. So we've already explained that everyone with, essentially in the United States needs a one-time test for hepatitis C. But since we aren't doing that, sometimes we can concentrate our efforts in places where hepatitis C is enriched. And so microelimination is investing your resource into a place where you expect to find people who are more likely to need an intervention. So rather than going to a low-risk primary care clinic where very few people that are tested are going to have active hepatitis C, if you concentrate your efforts in incarcerated individuals or places where there are more individuals who have a history or active injection drug use, then you're going to find more people with hepatitis C that you can engage in care. Hepatitis C seroprevalence among incarcerated populations in the U.S. is anywhere from 3% to 35%. And so our incarcerated individuals are an attractive population for screening and linkage efforts because we do know that we're going to be more likely to find people that are hepatitis C positive and also impact the communities around them by curing them and decreasing the risk of transmission in their communities. So hepatitis C treatment as prevention. So I know that Stacy's very interested in this as an infectious disease doctor, as well as Sue in primary care, as you want to make sure that you're impacting your community. But there are currently not recommendations for DAA to be offered as post-exposure prophylaxis. So if I find out that I engaged in high-risk behavior with someone who has Hep C, we don't have anything like PrEP. People who have been successfully treated and achieve SVR are no longer able to transmit hepatitis C, which is why really treatment is important for the individual, but also the community. And there are large decreases in hepatitis C prevalence and incidence if people who engage in high-risk behaviors are successfully treated. And there are beautiful studies that look at treating one person and seeing the impact in the community if they're in a high-risk setting, such as injection drug use. So good practice principles are really implementing hepatitis C screening, diagnosis, and management globally. And I'll open it up now to my colleagues because I think at least in liver clinic, we're pretty good about screening everyone that comes through the door. We're a liver clinic. I think in other places, microelimination or focusing on higher risk populations might be more realistic. And Sue and Stacy, I know that you're both passionate about this. So why don't you give me your opinion?
So I think the best practices now need to evolve beyond university-based health systems and beyond specialist offices, right? We need to be taking screening, diagnosis, and treatment to where we know that there are high prevalence populations for chronic infection. And so that means partnering with substance use disorder treatment programs. It means making sure that incarcerated settings are screening in a routine opt-out way and also treating while individuals are incarcerated as per AASLD-IDSA guidance. We need to be making sure the treatment and the diagnosis are brought to the patient rather than requiring the patient to traverse our complex healthcare system in order to access their diagnosis and care.
Yeah, I agree. I think this is a chance for us to really get out into the community. And when we talk about microelimination, I think another thing to think about is that it's not just populations, it can be also geographic or within a certain health system, right? So our health systems obviously serve our community. And I think that we all have an opportunity to kind of be champions within our hospital, clinic, whatever health system you're in to really help prioritize this, right? So I think I'm one of many hospitals that now in their emergency rooms and inpatient settings, we're doing this universal screening, and it's just built into our EMR to look to have an automated screening algorithm. So if somebody doesn't have a Hep C test within our system or in the health interface, exchange that goes across other health systems too, that we just add on that one-time test. And it's amazing how many people we have found. And they will tell us, but I've seen so many doctors. How come nobody's ever tested me for Hep B or Hep C? Because we're doing both. And so it's really interesting. We have to think of really a whole person approach as opposed to the siloed approach we currently have of like cardiologist as a cardiology thing. And we each kind of like do our own thing instead of thinking about the entire person. And what they might need. So I think this integrated approach for all syndemic screening and testing and bloodborne viruses is really helpful and can be done, I think, in an automated way. And so the next step has been really like with those patients, making sure they get linked to care. And within these systems, we found that navigators can really be helpful. And those navigators don't even have to be on site. They can do a lot of this remotely now. And that also opens up the opportunity to say, hey, telehealth is a great option for patients who have difficulty getting places, geographically or because of work. And so we've been able to see a lot of patients and treat a lot of patients without them even coming into the office. They can go to a lab close to them. And so I think we're really kind of thinking through, what we're talking about, the last mile of patients, right? Patients who haven't yet gotten screened and might have some barriers. How can we get past those barriers to make sure that they get treated and cured? And it's very fulfilling. I'd say this for any primary care doctor. Like, this is a really exciting area. There are very few diseases we can cure, and definitely not in 8 weeks. And you will see patients' lives completely transformed. They get this disease cured, and all of a sudden they have a new found hope and optimism about like other things that we found people ready to tackle their diabetes or obesity, like once they got cured for Hep C. So I think it's a really exciting thing to do in our practices.
Yeah, you've both mentioned the words opt-out, and I think that's also really important. So you can leverage your electronic medical record. And I know in our primary care clinics, if you're getting blood drawn and you have not been screened for hepatitis C, there's a little pop-up that says, we're ordering a Hep C antibody along with your labs. And and then you can decline that, but you have to actively choose to not add the Hep C test. And if you ignore it, it just goes, and your patient then gets screened for hepatitis C. And I think it's these measures where you don't, the default path is to test, because in, my experience, very few patients say they do not want to be tested for hepatitis C. It's a little different for HIV because when we have any one virus, we look for the other two. So if you have Hep C, you should be looking for Hep B and HIV, and vice versa. And I still do have patients that will say they don't want to be tested for HIV, or I was tested a long time ago, and you suspect that maybe they weren't. And so really kind of states to, at least in my experience, how stigma is part of this. But I find people pretty receptive to hepatitis C testing. Yeah. And then just like hepatitis B, moving treatment into non-academic settings is also really important. And I think that our AASLD-IDSA guidelines and our simplified models really show that Hep C therapy is very successful in non-subspecialty practices. And so if you have a big patient population and you have interest in treating hepatitis C, there are sometimes some state rules or hiccups in order to start treatment. But engage in an ECHO program, or, learn how to treat the population in front of you, because this is going to be also important for elimination. The last part of this, and we can talk a little bit with our colleagues, is really follow-up. So we'll come back to Carl. Carl does start treatment with sofosbuvir and valpatisvir for an anticipated 12 weeks. He's engaged in care in a motivational way. So I don't know, I think it was both Sue and Stacy that said that they use Navigator. So he's really emphasized on the importance of adherence. He has a couple of touch points, which are often remote phone calls or messages to make sure that he's doing okay, no anticipated side effects. He's not run out of his therapy. He got his refills if it wasn't all dispensed. And then he's given some education about the importance of taking his medicine, treatment as prevention. So I use that as a nice opportunity to remind him that close contacts, like your family, should also be screened. It always surprises me how many spouses come in and don't realize that they should have also been screened when the person sitting next to them also has Hep C. And I don't emphasize sexual transmission, but rather, you're in the same place where there's razors and toothbrushes, and however one person might have been exposed. And lo and behold, the CDC says everyone should be tested at least once. So even if you've never ever touched your spouse, you still should be tested. So we try to capture as much other screening when you have that index person there. Goal is cure. And you want to try to avoid reinfection. So talking about those risk factors in a neutral way, and then figuring out how you're going to manage him after he's cured. So there's a nice little graphic here that really says that if you have F2 fibrosis and no or less, and no other risk factors like metabolic dysfunction-associated steatotic liver disease or alcohol use disorder, you don't need to really continue to engage in liver-related monitoring. However, if you have risk of a liver disease that isn't Hep C, like alcohol use or hepatitis B or a MASLD, then you want to make sure that you're continuing to have that disease monitored. And if you had F3 fibrosis or more, I still treat my F3s despite the guidelines suggesting that I may not have to. I think F3 and F4, which are more advanced disease, I'm still doing liver cancer screening and talking to them about disease progression because it's often, sometimes someone who has very early cirrhosis might be misclassified, and there is still a risk of liver cancer. It may not meet the threshold that warrants liver cancer screening, but as long as I'm not blocked on that, I think that that's important for my patient and a reminder that they need to continue to invest in their health. Now that we've spent some time discussing viral hepatitis, let's hear from a patient advocate.
So when I had a loved one that was diagnosed with Hep C, I would take the person to a clinic or liver clinic visits and things, but I never disclosed that I happen to have hepatitis B. And this is due to that internalized stigma. I really felt that this was this dark secret that I had to hide. One of my biggest regret is that I never disclosed that I'm also someone living with hepatitis. And that's the part that's so artificially constructed because of the stigma, because of the shame, because of the misconceptions associated with hepatitis. And then I think there's these cultural contexts that kind of prevent us from openly sharing. So as painful as it is for me to share and be vulnerable and share this story, I feel it's important to be told.
I will go now to the summary slides. AASLD-IDSA recommends universal DAA treatment for all people with hepatitis C infection, so very few to no exceptions. Too few people living with hepatitis C are treated despite the availability and access to very effective therapies. Attaining an SVR12 or making sure that you demonstrate that the virus is gone 12 weeks after stopping therapy does offer reassurance. If you did not get that test because your patient absconded or refuses to get their blood drawn, you can know that if they took their drug, there's a very, very, very good chance they are still cured, although we do still like to confirm that. Incomplete adherence to DAAs can contribute to treatment failure, but often they're cured even if they haphazardly took their drugs. We don't encourage that, but it's still important to retest for cure because some of them really are still cured. And then people who have successfully achieved SVR no longer transmit hepatitis C. So it's really important that we engage these individuals from a community standpoint, not just an individual standpoint. So I want to thank everyone for joining us today and thank my colleagues for sharing their incredible insights. We hope you found this activity useful for improving your care of people living with viral hepatitis.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Hepatitis B Foundation. This program has been supported by an independent educational grant from Gilead Sciences, Incorporated. To access all materials for this activity, visit peerview.com/EWQ860.